Hello and welcome to another video for chapter 35 where we're talking about alterations of the female reproductive system. In this video we are going to talk about pelvic organ prolapse and benign growths and proliferative conditions. So starting off with our pelvic organ prolapse, we know that the area of the pelvis has a ton of different ligaments, mostly cardinal ligaments, that serve as major support in the thickening of the endopelvic fascia. But we can start to lose the integrity of these ligaments and fascia, and also our perineal muscles when there is stretching or possible ripping during labor and delivery, or there may be some congenital defects in the muscles of the pelvic floor that could lead to prolapse taking place in areas such as the bladder, urethra, or the rectum. And of course, some other ways that we are going to start to lose the tone and strength of our muscles and fascial tissue is through the process of aging. So we do start to get some progressive descent of our pelvic support structures that could cause some pelvic floor disorders such as urinary and fecal incontinence. And the truth is that women have some version of our pelvic organ prolapse taking place, but aren't really going to cause any symptoms. And we do see this more often in people who are obese or have had hysterectomies. There also seems to be a strong familial tendency, and there are certain people that have risk factors. For instance, for people who are nulliferous, meaning they have not given birth yet, risk factors would be if they have occupational activities that require them to lift heavy things, or they may have a chronic medical condition such as chronic lung disease or refractory constipation that may weaken some of these pelvic structures. Other causes could be due to direct trauma, pelvic floor surgery, pelvic organ cancers, or damage to pelvic innervation. Specifically, the pudendal nerve is when that's really affected. One of the more common organs that prolapses is the uterus. So this is when we start to see a descent of the cervix or the entire uterus itself into the vaginal canal, or completely through the vagina, which would be a severe case. So you could see in the illustration here that we have the different grades. Grade 1 is not treated unless it really causes discomfort, and grades 2 and 3 are going to cause feelings of fullness, heaviness, and a collapse through the vagina. They may also have difficulty urinating, and so for treatment, we can add a pessary, which is a removable mechanical device that's going to hold that uterus in position. We can instruct the patient to do Kegel exercises, which is going to help strengthen the pelvic fascia by having these repetitive isometric tightening and relaxing of the pubococcygeal muscles, which is a perineal muscle. You do want to make sure that the patient does not do these with a full bladder. Always empty the bladder and then do the Kegel exercises to prevent UTIs from taking place. We can also do estrogen therapy for women who are going through menopause, and also surgery as a last resort to repair any tears or damage to ligaments, or maybe add a mesh to give more support. Maybe a hysterectomy can also be performed, but that of course depends on the severity and how the patient feels about that. And here are some other cases where we have prolapse taking place. First, we'll talk about a cystocele. And so here we can start to see a descent or protrusion of the posterior bladder wall and the trigone into the vaginal canal, which is pictured over here. And this tends to take place in an area where we have a weakened part of the vaginal musculature, and that can be due to the process of childbirth. It could also happen with aging, being obese, or lifting heavy things. The clinical manifestations are sometimes no symptoms. Other times there's sensations of pressure, incontinence, and back pain. And the treatment would be surgical repair of the vagina, possibly with a prosthetic mesh there to give some more support in the area where that protrusion was once taking place. Now with a rectocele or a proctocele, we are going to have a bulging or protrusion of the anterior rectal wall into the posterior vaginal wall, so it invades that vaginal canal there. And again, this is due to a weakened part of the vaginal musculature there. And this could be due to injury during childbirth or some type of pelvic surgery or the aging process. The risk factors are going to be, again, being obese or being in a postmenopausal status. Clinical manifestations would involve the bulging mass in the posterior mucosa that could cause that rectum to tear, and there's levator ani muscles there that can stretch or tear as well, and we could have difficulty in evacuating the bowels. And to treat this, we would again utilize surgical repair of the vagina to push that bulge back into its place and strengthen the posterior vaginal wall. Lastly, we have an enterocele, and this is when we have a herniation of the rectouterine pouch. You may have learned that this is the pouch of Douglas as well. That is the space between the uterus and the rectum, and so it gets pushed into the rectovaginal septum, and this could be congenital or required, and we can utilize surgery in order to get things back to where they need to be. Now let's move into benign growths and proliferative conditions, starting with our benign ovarian cysts. Now, our benign cysts of the ovary can take place at any time during our lifespan, but we do see it that it is going to be more common in our reproductive years, especially when we have those hormonal changes taking place, such as in puberty or menopause. And the most common are going to be these functional cysts that are going to be variations of our normal physiological events. So the two types that we really have that are the most common are follicular cysts, and these are going to be fluid filled, so you kind of see it depicted here, and then this is an actual real life follicular cyst that we see, or it could be a corpus luteum cyst, which you see pictured down over here, or here's an illustrated version of that is going to form based on the granulosa cells that get left behind after ovulation takes place. And these cysts tend to be highly vascularized, but will regress within that ovarian cycle, but sometimes they can enlarge and rupture, and because they're highly vascularized, it could cause hemorrhaging. Now, with both of these, we are going to see that it is unilateral, and if we think about that ovarian cycle, it's one ovary typically that's going to release an egg. So every month, about 120 follicles are going to be stimulated by the follicle stimulating hormone, and maybe I'll point that out over here. So as that follicle stimulating hormone is being secreted, we stimulate all the follicles, but generally just one is going to succeed in having ovulation take place of a mature egg or ovum. But if that one follicle does not dominate and create a mature ovum, then that's when we can create a cyst. So we never get that ovum to reach full maturity. And another type of cyst that can develop is a dermoid cyst. And this is an ovarian teratoma, meaning that we have all three germ layers represented in here. And we find that it's common in ovarian neoplasms. These types of cysts can contain things like skin or hair that you see illustrated here, sebaceous or sweat glands, muscle fibers, cartilage, bones such as teeth or fat. And they tend to be asymptomatic, but they can have a malignant potential. So we have to evaluate these carefully so that they can be removed. Now, something that is rare but possible is ovarian torsion due to a cyst becoming quite enlarged that it could cause a twisting on its ligaments. Now, when that happens, we reduce the blood supply to the ovary, which could cause extreme pain that is acute, severe, and unilateral, either in the abdomen or pelvis, or maybe it's radiating to one or the other. So this is a gynecologic emergency and it needs to be treated surgically right away. And here's just a summary of some of those cysts that I had described and some illustrations to go along with it. So I won't repeat myself, but you could see it summarized on this slide. Next up, we have endometrial polyps, which are going to contain glands, stroma, and blood vessels. We typically see that these develop in women between the ages of 40 and 50 years old, although they can take place at any age. And we can structurally classify them as being hyperplastic, atrophic, or functional. Now, when we say they are hyperplastic, that means that they have this pedunculated look to it, meaning that there's a stalk and then there's kind of like a mushroom or widening at the other end. And sometimes this is mistaken for endometrial hyperplasia or an adenosarcoma. So one of these here looks like a hyperplastic polyp. Another type we said was going to be atrophic. So this really means that it's inactive, and we typically see it in postmenopausal women that are going to have a glandular architecture that's going to resemble endometrial cystic atrophy. And our last type is a functional polyp. This means that the architectural and cytologic features of the gland are going to be in synchrony to those of like the remainder of the endometrium. Unfortunately, especially the ones that are functional are going to cause intermenstrual bleeding, and they can also cause excessive bleeding to take place. So if necessary, these lesions can be removed with small curved forceps. This over here are polyps that we are seeing through a hysteroscopy, which helps us visualize these polyps so they could be removed, but it's not always necessary. There is a high rate of spontaneous resolution. Next, we have leiomyomas, and these are commonly called myomas or uterine fibroids, and unfortunately, they are the most common uterine growths. About 70% of women are going to experience them by the time they reach 50 years old. Luckily, though, they are benign tumors of smooth muscle cells in the myometrium. So we see a mid-sagittal view here of the uterus, and you could see the myometrium, which is the smooth muscle here in the uterus, and a couple illustrations of these fibroids. And because they're estrogen and progesterone sensitive, we tend to see growth in the reproductive years. Unfortunately, the cause is unknown, but there is a theory that the growth hormone may influence the tumor formation. The clinical manifestations that we see depends on the size and the location of where the fibroid is, but if the fibroid is large, there may be more abdominal pain and pressure. There also may be vaginal bleeding and discharge, maybe some backache, constipation or urinary frequency, and at times it may prevent pregnancy. And based on where the fibroids are, we can classify them as subserous. So if we find them kind of protruding into the area where the perimetrium would be, then we also have our intramural, which means they're kind of embedded within the smooth muscle here, or submucous, where they are protruding within the lumen of the uterus. Now, if they're small, we really don't need to do anything for treatment. We just kind of monitor it. But if it is large or we have multiple masses, such as the picture that we see over here, then they may be surgically removed or a hysterectomy may be performed. Next, we have adenomyosis, and this is when we see endometrial tissue within the uterine myometrium. Unfortunately, we don't know what the cause is in allowing this type of tissue to migrate over to the myometrium. And some patients are going to be asymptomatic. Others may experience abnormal bleeding. Secondary dysmenorrhea is going to become really severe as this disease progresses. We also may have uterine enlargement, which can lead to other issues within the pelvic space. There is tenderness and also chronic pelvic pain, and it can cause infertility. Now, to diagnose this, we can perform an ultrasound or an MRI, and to treat it, we can use NSAIDs to make it manageable, hormonal contraceptives, or an IUD. If it is severe, there could also be a hysterectomy performed. Next up is endometriosis, which I'm sure majority of you have already heard about, but it's when we have functioning endometrial tissue that is going to be found outside of the uterus. And this endometrial tissue that we find in other areas is going to respond to hormonal fluctuations of the menstrual cycle. And as long as they have adequate blood supply, we'll see that that endometrial tissue proliferates, breaks down, and bleeds like a menstrual cycle. And with that bleeding, we might have an inflammatory response, which can lead to fibrosis, scarring, adhesions, and pain. And we could see some of that tissue that has been bleeding that contain kind of like a brown discharge in the areas where that tissue exists. Now, the cause for this is unknown, but there are some theories that exist. For instance, in 1927, it was thought that it was due to retrograde menstruation. Today, we know that all women have retrograde menstruation at some point, but the thought is that women had obstructed menstrual flow, and therefore the fluids would move back into the fallopian tubes and into the pelvic cavity, and those endometrial cells would then implant somewhere in the pelvis. Others theorize that it's due to the alterations in cytokine and growth factor signaling, and there was the theory of coelomic metaplasia, in which they looked at the tissues, specifically the peritoneal mesothelium, the Mullerian ducts. If you remember, those are what in the embryo or fetus is going to then develop into the uterus and the fallopian tubes, and the germinal epithelium of the ovary, and that they were all derived from the cleomic wall epithelium. The other theory is the embryonic cell rest, or our primitive embryonic cells that become activated and then turn into our endometrial tissue. The other theory is iatrogenic mechanical transplantation, or through our lymphatic and vascular system, it disseminated this endometrial tissue into other areas. And there's also been research that found that there is a genetic predisposition as well. Now, as far as sites on where we could find this endometrial tissue, the most common areas are the pelvic peritoneum, in areas such as the pouch of Douglas, or the peritoneal surface of the uterus, the cul-de-sac areas as well, and the ovaries, areas of uterine ligaments such as the sacropelvic ligaments, or the rectovaginal septum, and they can even be found in areas such as the bladder or the large intestines. And the clinical manifestations that patients can have are dysmenorrhea, pain with defecation, changes in their pattern of menstruation, anemia, and fatigue. It's also highly associated with infertility because of the scarring and adhesions that we mentioned in the slide before. And for treatment, there unfortunately is no curative type of treatment, but we treat to prevent the progression of the disease and alleviate pain. And we want to restore or maintain fertility. We can also use NSAIDs and hormonal agents if they're needed. Surgical intervention, for instance, they have done surgeries to remove the endometrial tissues, but it's not a guarantee that that tissue will not grow back. And sometimes it can even grow back to a greater extent. And of course, as a last resort would be a total abdominal hysterectomy. And I wanted to include some images here of some endometrial tissue. I was able to see a lot of this in the OR and when they went in with a laparoscope, so we can really visualize these. And in certain cases, of course, we're removing the tissues, but sometimes it's just to confirm diagnosis.